Hit the subscribe button or visit us at auau.auanet.org.
Good afternoon. Thank you all for coming back from lunch. We are going to talk now about PARP inhibitors and precision medicine for patients who have metastatic castration-resistant prostate cancer. These are my disclosures, none of which are relevant to this talk, but I will also make the disclosure that as a urologist, I refer and rely on multidisciplinary care for these patients. So I do think that when it comes to PARP inhibitors, urologists are a really important part of the treatment team for our patients, but we may not necessarily, at least at this point, be the ones who are prescribing in all cases, or the ones who are kind of driving the bus. But these are our patients and the ones who we have a relationship with, and we often are the ones who obtain tissue. We're the ones who see them regularly and can assess when they're having symptoms related to their treatment of their advanced prostate cancer. And so it is important for us to be aware of these therapies, aware of the side effects, and kind of know what's coming down the pike. And things are evolving so rapidly that who knows, it might be some part of everyday urologic oncology practice. So here's the outline, and we will start with some of the nitty-gritty and basics, and then we'll talk about mutations. I know you've heard a lot about mutations today, but really it's an important part of advanced prostate cancer, particularly for the mCRPC patients, and then go into some of the data. What is the mechanism of action? So poly-ADP ribose polymerase, PARP, repairs DNA damage, and it is dependent on this process, kind of unique process called synthetic lethality, also known as kind of manufactured lethality, where a mutation blocks one particular pathway that's important for cancer survival. So the cancer uses a different pathway, and when that pathway becomes mutated and no longer is able to be repaired, there's genomic instability, ultimately leading to cancer cell death. So PARPs block that dependent pathway. They are oral agents, like many of the advanced prostate cancer agents that we're using now. How are these given? As many of you know, it's not involving an IV or an infusion center. They're oral medications, and they're dosed BID based on their FDA approvals. The ones that are currently FDA approved are given twice a day, and it's fairly straightforward for the patients. They don't have to be given with steroids or other agents. There are no food restrictions. Generally, they're well tolerated, like many of these agents in advanced prostate cancer. If you look at the data, which we'll go through in a little bit, the most common adverse event tends to be related to thrombocytopenia or anemia. And as you all know, if in this patient population, many are older, have had prior therapies, especially with the initial approval of PARPs. They've been treated with multiple agents that could already lead to myelosuppression or have caused anemia. And so that might be contributing to the fact that we are seeing so much anemia for patients who are on PARP inhibitors. There's also GI side effects, nausea, vomiting, diarrhea, and like many of these agents, there is some associated fatigue. So as the urologist who's co-managing these patients and seeing them, you're kind of at the front lines of the person to identify and talk to your patient about them, and then make referrals to primary care, to the medical oncology and other teams who can maybe help manage that with you. What do you do when there's associated toxicity? You can interrupt the dose or try and reduce the dose. There's really limited data currently on contraindications to PARP inhibitors. You know, if your patient was severely anemic or had some sort of bone marrow issue to start off, you might not be able to use it. But again, in a multidisciplinary fashion, you're going to collaborate with colleagues to help make the decision about that. What about resistance? Like all of these medicines, they don't last forever. And the thought is that over time, some patients may become resistant to PARP inhibitors through a reversion mutation that restores the original pathway. So essentially, it's like giving the medication to a patient who does not have that important genetic deletion or HRR mutation that we're going to talk about. So PARP inhibitors really aren't active anymore in patients who develop this resistance. And I think we're learning a little bit more about who those patients are and how that happens. So current indications. Right now, PARP is approved for patients who have metastatic CRPC, who have DNA repair defects, and have failed some prior therapy. It is being evaluated for patients in the first-line setting for metastatic CRPC, and there's some data in support that's emerging and exciting about a response in some patients who don't have identified mutations, but right now these are the current indications. We'll talk about single-agent use of these two FDA agents, Olaparib from the PROfound trial from 2020, and RUCAPARIB Triton-2. Again, both metastatic CRPC patients with identified mutations who have progressed through prior therapy. Piggybacking off of the excellent talk by Dr. Gamella this morning, we know that there are strong genetic associations for prostate cancer, particularly homologous recombination repair gene deficits, and a number have been identified. We know that BRCA2 is really one of the most important, and these mutations have important implications not only for response to therapy, but also for family members, for enrollment in clinical trials, and genetic testing is really important. In the past 5, 6, 7 years, the indications for genetic testing have really taken off based on our improved understanding of the genetic component. And we know now, based on guidelines, that patients who have localized disease, high-risk localized disease, or very high risk, it is recommended to undergo genetic testing. And so we as the urologists are implementing that when appropriate. And then certainly in the metastatic space. We hear a lot about germline and somatic. They are different, and we've had some robust discussions this morning at our tables about why test for both. And I would say that it is indicated and important, as you have heard, to test for both types of mutations. And there can be some overlap, but they can also produce different results. And both of them are important for determining future therapies. Germline is inherited. It's in every cell in your body, and it does pass from one generation to the next, and as we know, has important implications. Somatic, not inherited, can occur sporadically, does occur sporadically, is not passed on, and again, can guide future decision-making. Somatic testing can be repeated as well. We don't generally repeat germline testing, but somatic can change over time, and if you have a patient who you have a suspicion that there's a somatic mutation that was not detected before, they're behaving clinically different, it can be appropriate in some patients to repeat somatic testing and see if there's a mutation that was not detected previously. There are important pre-test and post-test considerations for our patients. One of the big limitations that is often discussed among urologists is, well, we don't have that many genetic counselors. And it's true, there really is a bottleneck when it comes to access to genetic counselors. But we can talk to patients about why we're doing the test, what the possible outcomes are, and then after the test is done, make a referral when appropriate to genetic counselors. So we don't have to be the total experts in genetic counseling for our patients, but we should be able to talk to them about what the implications of the test are in general. And you can see the recommendations here, which are clear in NCCN and recommended by the AUA. And so the recent updated guideline, which just dropped this week, congratulations to Dr. Cookson and all, does recommend offering germline testing and considering somatic testing and genetic counseling to patients who have metastatic prostate cancer. And then for metastatic castration-resistant prostate cancer, we should offer germline testing if not already performed. And often it is performed in advance of the metastatic CRPC state, and that's because of the important implications on management. So now let's talk about some of the data. PARP inhibitors, I like to think about them in kind of discrete boxes, single agent or combination therapy. And then I like to think about it in the first line setting or after failure of multiple therapies. And so we'll start first with the FDA-approved agents, again, Olaparib and RUCAPARIB, and then talk about the combinations that are being reported on currently. These last two bullet points here are a reminder to me to talk about the number of studies that are ongoing now. If you were to go to the clinicaltrials.gov, there's upwards of 30, close to 40 or 50 trials that are looking at PARP inhibitors in advanced prostate cancer. And in a number of different settings combined with different agents. There's one looking at PARP inhibitors in the neoadjuvant space, and then in combination with other agents, including radiopharmaceuticals. And I think we heard a little bit about some of that this morning. So it's really, really exciting to consider that. Also, it's important to consider that this patient population is really heterogeneous. So we're seeing patients who are arriving at their metastatic castration-resistant state having had different treatments. Some, less now, but some have only had ADT. Others have had ADT with chemo. Others have had androgen receptor therapies. Others have had triplet or treatment intensification. And so it's kind of a really heterogeneous group, and that may explain some of the kind of heterogeneous outcomes that we're seeing. The PROfound trial had patients who had progressed through prior therapy, so novel hormonal therapies, and all of these patients had pre-specified mutations. The study broke the groups into two based on their mutation status. Cohort A, you can see, had BRCA1, 2, or ATM mutations, and cohort B had other pre-specified gene mutations. In this trial and many of the trials, we see radiographic progression-free survival as the primary endpoint. And there is a robust debate about that as an endpoint. We're used to seeing overall survival as our endpoint, and that's an understandable primary outcome. So what exactly radiographic progression-free survival means and how that translates into overall survival, I think as the data matures, we're seeing more and learning more about that. So primary endpoint and then secondary endpoint looked at the overall cohort, not just the BRCA or ATM mutations. And here you can see the results. In the top, we have the image-based progression-free survival for that first cohort with the 3 possible mutations. And the hazard ratio here is favorable with statistically significant findings. And then in the overall survival, they also looked at for cohort A. We see that there's it favors treatment with the Olaparib versus physician's choice. And that's a pretty strong comparator there, because we know that patients do quite well with novel hormonal therapies that they have not seen in this space before. Then there's Triton-2, RUCAPARIB. Again, mCRPC patients who have progressed, in this case, on prior androgen receptor therapy, as well as chemotherapy. And like the prior trial, these patients had pre-specified somatic or germline mutations in HRR. 3 cohorts here. We have BRCA 1 or 2 or ATM, and then measurable disease, so visceral or nodal disease. And then cohort B, BRCA1 or 2 or ATM without measurable disease on imaging. And then the C cohort is other HRR gene mutations, and they may have had measurable disease or not. Primary endpoint here is in A and C is this radiographic progression-free survival, objective response rate, and then in cohort B, it's a PSA response. They also looked at safety and efficacy. And you can see the results here with the top A looking at confirmed radiographic response that was favorable for patients who received the RUCAPARIB. And then we also see the PSA response in that cohort B, favoring patients who had received RUCAPARIB, and it was well tolerated. So based on these results, there was an accelerated FDA approval for RUCAPARIB in patients who had progressed with specific mutations through 2 therapies in the metastatic castration-resistant space. And our updated guideline indicates that here we should offer PARP inhibitors to patients with these germline or somatic homologous recombination repair gene mutations following prior treatment with enzalutamide or Abi or taxane-based chemotherapy. And you can see that detection of the germline of the mutation on germline or somatic testing is important. The phase 3 data was just published very recently in the New England Journal looking at RUCAPARIB or physician's choice in patients with metastatic CRPC. And here the mutations were BRCA1 and 2, again with ATN, but what's a little different is that chemotherapy was not required here. So patients had progressed after novel hormonal therapy. The comparator arm, again, is physician choice with radiographic progression-free survival, and we see improvements with patients who received the RUCAPARIB compared to an additional novel hormonal therapy or chemotherapy. So the duration of imaging-based progression-free survival significantly longer with RUCAPARIB than with control medications. And the BRCA alteration, this was particularly true. So now let's talk about combination therapy. Why would we want to combine a PARP inhibitor with an androgen pathway inhibitor? And there is a lot of excitement and talk about this, and we think that it's synergistic. I don't think we can say with 100% assurance right now that it's not additive, and no one has necessarily asked that question, but it is postulated that there is a new type of synthetic lethality that occurs with this combination therapy, and that there may be creation of this BRCA-ness with androgen pathway inhibitors. And we also know that AR signaling regulates or promotes DNA repair. And so combining the two makes sense, and preclinical studies indicate that there is a benefit to combination therapy. This is a phase 2 trial looking at Olaparib with abiraterone in patients who have mCRPC. And these patients had prior docetaxel and were considered candidates for abiraterone. And you can see that they were compared abipred with Olaparib versus abipred plus placebo. And with the primary endpoint of radiographic progression-free survival, we see a benefit. But here, importantly, and this is another sort of box to consider as we're characterizing these different studies, there was no stratification by mutation status. This was kind of an all-comers, and the intent to treat analysis included all-comers. Retrospectively, their mutation status was evaluated, and we can see that there is a benefit here for all-comers. The longer-term kind of follow-up here is PROpel, which was originally presented at ESMO by Dr. Saad in the fall of last year. So now it's phase 3, looking in the first line for patients who have metastatic CRPC. Prospectively, there was an assessment of their mutation status using either Foundation 1 testing or ctDNA testing, and this occurred after randomization. We see treatment is continued until there's radiographic disease progression or some toxicity, and the primary endpoint, like we've seen in these other studies, is their radiographic findings. There's a significant benefit here for the patients in the first line with combination therapy. Secondarily, overall survival was evaluated, as well as gene mutation status and safety and tolerability. So while it was not necessarily the initial presentation statistically significant, the overall survival, there was a trend towards that being significant at the interim analysis. And then at GU ASCO this year, it was presented again, and we see the overall survival and safety benefiting patients who received combination therapy with PARP inhibitor and an androgen receptor targeted agent here, abiraterone and Olaparib, with favorable side effect profile, anemia again being kind of the most important. Magnitude also has been presented at GU ASCO. This is a different PARP inhibitor than we've heard about before. And combination therapy here in the first line, looking at abipred with niraparib versus abipred with placebo in the first line setting. We see that prospective HRR gene alteration assessment with the primary endpoint of the radiographic findings, again, then looking at overall survival as well as need for additional therapy and patient symptoms. And in this trial, there was a significant improvement in radiographic progression-free survival, particularly in patients who had the BRCA1 and 2 mutations. But when we look across the host of mutations that were tested, there was still a significant advantage to receiving the combination therapy. And then finally, TALAPRO-2. This is a phase 3 study looking at first-line therapy, so before any chemotherapy or enzalutamide or abiraterone. And here patients received talazoparib, another of these kind of newer PARP inhibitors, with enzalutamide versus enzalutamide and placebo. And patients were stratified afterwards for their mutation status, and we can see that there was a delayed progression and death in the overall population. And there's still accruing information about the study is not entirely matured yet, and so we're still waiting to see. But it just brings up an interesting discussion about the importance of the HRR mutations. The current indications indicate that that's important for our patients, and that's the FDA approval. But since some of these trials are indicating that some patients may see a benefit without those mutations, I think we are looking to see kind of what the future holds. Current NCCN guidelines indicate that Olaparib and RUCAPARIB are appropriate for patients who have mCRPC with prior novel hormonal therapy or prior docetaxel and novel hormonal therapies. And just wanted to finish up with our new guideline statement, which is pretty similar to the old guideline statement, but again, indicating the importance of metastatic, castration-resistant, identifiable gene mutation prior therapy. Thank you very much.